Hello, I'm Dr. Vipul Janardan. I will be talking about navigating psychiatric care in first trimester, uh, essential assessment and treatment insight. So it is very important topic. Every psychiatrist scratch their head when it comes to the pregnant woman because this is very crucial period for the baby as well as for the mother. Uh, this is non-pharmacological measures will definitely helpful and give a better way while taking care of the pregnant woman. So let's delve into it. So please change the slide. So what are the important thing like what while we are taking care of the pregnant woman, first is risk benefit assessment. So what are the four things? So we have to consider four things about that. So first is like risk of untreated maternal psychiatric illness. And another is like benefit of avoiding medication exposure. Third is benefiting of adequate control of maternal illness. And fourth is risk of medication. So before we move forward, it is always to keep in mind about the risk benefit assessment to so that there are four things we should consider while choosing any options. First, risk of untreated maternal psychiatric illness, benefit of avoiding medication exposure, and adequate control of maternal illness, and risk of medication. These four questions we should ask ourselves before we take decision in treating patient of first trimester pregnancy. So, in this line, what are can you please change the slide? What are the things? What are the interventions we can do? So, in general, consensusly, these are the things that we when we do the literature review, and it came out like psychotherapy, lifestyle modification, mind body intervention, brain stimulation therapy, support groups, and peer counseling. These are the mainstay that is helpful in or non pharmacological measures in in this first trimester of pregnancy. Other is like supportive psychotherapy, CBT, and conjoint therapy. Please change the slide. uh, so this is like I've told, supportive psychotherapy, CBT, and conjoint therapy. Can you please change the slide? Uh, So, what are the other non-medicinal interventions? These are improvement in nutrition and diet, elimination of caffeine, nicotine, and alcohol, facilitation of the sleep hygiene, reduction of stressor, relaxation techniques, and light therapy. So, these are the other non-medical interventions that can be given in the first trimester pregnancy. Change the slide. So, so why we should avoid pharmacotherapy in first trimester? Because this is a very crucial period, embryogenesis, and there is a potential risk to the fetus. There is a risk of a spontaneous abortion, and moreover, limited data is available. Prefer non-pharmacological treatment. So, in that case, consider ECT or RTMS. Please change the slide. Uh, So ECT when to consider and when not to. Certainly, when considering the use of ECT during the first trimester of pregnancy, the potential benefit may include the providing effective relief for severe psychiatric conditions such as treatment-resistant depression, mania, or catatonia. In cases where the maternal mental health poses significant risk to the well-being of both the mother and developing fetal, ECT may consider as a potentially life-saving treatment option. However, it is essential to underscore that the decision to utilize ECT during the critical phase should be carefully assessed by a specialist medical team considering the potential risk to the fetus and the mother. Please change the slide. So, ECT administration in early pregnancy. So there is a limited guidance on administering ECT in early pregnancy with difficulty in fetal monitoring. There is a potential risk ECT links to post-procedural vaginal bleeding uh, and increased risk of abortion. There is causal relationship. that is illustrated by case reports. There is a chances of congenital hyaline membrane disease and hypertrophic pyloric stenosis due to extensive antipsychotic use and antidepressants use. Please change the slide. So when you consider ECT, so when previously responded well with the ECT, well tolerated for both the patient and the fetus, when there is a mild symptoms and the patient already on the psychotrops, and discontinuation of the medical trial can be given. Please change the slide. So fetal health monitoring and intervention. So transient fetal complication is the most common complication that is associated with and with ECT, and there is fetal bradycardia and post ECT uterine contraction. So you can take the precautionary measure by considering both pre and post ECT tocolytics treatment to mitigate the risk of preterm labor. Now one more thing is transmagnetic stimulation, that is a very so evidence based, like in the peace sleeping et al has done, and they have shown that in case of treatment resistant depression, active rtms is in sham control study shows a mean MD percentage reduction of 45.21 versus 25.04 for sham rtms. When aggregated scores were translated into notional CGI score for the treatment of depression, the notional CGI score difference between the RTMS and the sham RTMS was zero point 0.5 in favor of RTMS. So this is the thing, the researches that I have given you, I have shown you in the favor of RTMS. So we can use this technique because it is favorable in terms of the both baby and the baby and the mother. As such, there is no complication associated with the RTMS. Similarly, this is another done by Gogman Hisley et al. So, um, can you please change the slide? Yeah. So this is what I was talking about. Please change the slide. Yeah. So this is another evidence supporting the fact that RTMS is helpful in case of. Can you please change the slide? So in case of anxiety disorder, so this is what are the things that we can use: psychological CBT, individual session CBT, and IPT group session, and mindfulness. uh, Coming on to depressive disorder, please change the slide. So this is the one more publication that in the clinical ops gynecol journal that shows the non-pharmacological intervention prevention and strategies for depression during pregnancy and the postpartum. So what are these are, please change the slide. So these are the interventions that you can use, like groups intervention focused on education and support. So it lowered the depression severity on EDPS score. Preparing for the parenthood course aim to improve social support and problem solving. So no significant depressive group score in self-reported depressive symptoms. So these are the other researches that has been done, and which there is like we can like use this, and in case of non-pharmacological, what are the interventions, and then we can judge accordingly. So, so in case of OCD, like mild to moderate OCD, exposed response behavior therapy is recommended. As such, no definitive guidelines are there, and risk benefit analysis to be done. Nulli gravida period is important for adherence of the pharmacotherapy to prevent the relapse. Coming on to next slide, for schizophrenia. So early intervention that include preconception counseling reduces relapse and emergent hospitalization need. There is cognitive remediation therapy, occupational therapy, insight oriented therapy, art therapy, family intervention, and social skill training. So these are the other things, challenges of using non-pharmacological treatment during first trimester. Cost effectiveness is there, adherence not easily available, and no effective guidelines are there. So these are the challenges that we go. So in that way, I just want to conclude the about like what are the things that we can use during as a non-pharmacological measures or in this series of thank you very much.
Okay. Okay, thanks a lot. We leave it, yeah. Do you want me to stop it or just leave it?
Okay, we can like this.
Okay, I take it off, yeah. Okay, that's okay. Yeah, don't rush too much, So next time, possibly just calm down. I think it's always you always have to rush through things, and then you just take your time.
Okay.